Welcome to the Mindset Matters, the podcast where psychiatry, medicine, and real human experiences collide, all through the eyes of two psychiatric PAs.
We're your hosts, PA Mercedes Dodge and PA Jessica Spissinger, two passionate psych PAs on a mission to bridge the gap in mental health care.
So whether you're a provider just here to level up your psychiatric insight, increase your mental health skills, you're in the right place.
Each episode, we shine a light on the incredible work PAs are doing in psychiatry and beyond. Our goal is to build a community focused on better patient care, professional growth, and personal well-being.
This podcast, a little disclaimer, is for educational purposes only. We're not here offering medical advice, psychiatric advice. If you or someone you know needs support, please reach out to a licensed mental health professional. All right, guys, let's dive in. All right, welcome to Mindset Matters. I'm here with Kathryn Werner. She is an awesome psychiatric PA. I've had the pleasure to meet her on social forums, and we're hoping to do co-speaking together. She is the owner of White Pine Mental Health and Wellness. So she's a senior consultant. She's a practice owner. She has like 15 years of experience in psychiatry, plus a background in GI, hepatology, internal medicine. So she doesn't look as old as that resume, but
Not at all.
Kathryn, thank you so much for being here. Let's dive in.
There's something about your name. I know we have connected over the past, even the name of your practice, White Pine Mental Health. Maybe you put it out in one of the psychiatric PA groups at some point. And I definitely think that your background, it's very much in line with Mercedes. I'm excited to hear the whole picture of how you've gotten from there to here.
I'm really interested in how you become a psychiatric PA, about how your rotation went when you were a student. How did that go?
I hated my psych rotation. Like, it's my least favorite rotation ever. And I think what happened, bless the psychiatrist heart, I think the school placed me with him and he didn't really know that's what was happening. I just show up and he's like, I wasn't anticipating a student, but you're here. Let's make it work. He was outpatient. I would sit in the office until about noon, never to speak to patients, which given his clinic setting was appropriate. But it was just boring to sit there and listen all day. Then about noon, he would be like, okay, well, you might as well just go home. It's more of the same. So, I mean, as a student, I didn't mind going home early, but at the same time, it just was not my cup of tea. I really wanted to be doing something procedural, like surgical assisting, but knew that from school, I really wanted to do a year or two of primary care, just to solidify all the things that we learned before I quickly forgot them. So I got hired by a psychiatrist to do the physical medicine at the psych hospital. I was going to do all the intake physicals and manage whatever came up. This was in 2007. The hospital had never had a PA in the building and they would not credential me. So months went by. I have this, contract that I'm really excited about. The physician is wonderful and cannot start working. And so finally she said, look, we've tried. You can either come work in the office or you can go find another job. I was like, well, I guess I'm just going to give it a shot. So I did. And it was a great experience. She was a great teacher. There was 2 nurse practitioners that worked there. And then there was a primary care physician. They really gave me plenty of time to learn. I would see 1 or 2 patients a day, shadow, read, study, and they were really patient and kind with all of that. I think in that process, I really learned to love psychiatry. I did that for several years. And then when my husband's career moved us across the country, I needed a new job and couldn't find anything in psych in the DC area. So I ended up doing a short-term thing in GI and hepatology research. I was a sub-investigator for some of the new hepatology, like hepatitis drugs that are out now, which was really cool. Some of the first prescriptions of the HCV clearing drugs I was involved in and prescribing. That was awesome. Once we got through the big push of that, I ended up in outpatient family medicine, internal medicine, and we did a little bit of urgent care for about 3 years. And then back to psych once I had my kids, took a little bit of time off. And then when it was time to get back into the workforce, I worked for a few outpatient.
It's interesting, having had that rotation, which was such a bad experience, the psychiatrist there didn't really do much to help make it any better.
I think he was just kind of in over his head too. He was not expecting to have a super nice guy and like a great clinician, but I just don't think he was anticipating his students.
And you had such a great experience with the other psychiatrist with that first job.
Yeah, I think it was just really cool to have that time to really dig in and study. And I just would just sit with my books and like I had a great book on interviewing and diagnosing and just found that really fascinating. And then just seeing we had such a wide variety of patients at that clinic. You could be seeing everything from a CEO with a little bit of anxiety to an acutely ill schizophrenic patient back to back. And so that was just really fun to see just the huge variety of people.
Yeah, I mean, I think one of the things that when I did my transition to psychiatry, I was doing family medicine and no one had hired a PA before. And it's kind of
Gotcha.
similar. It's like we had to advocate, we had to kind of create the curriculum. Because as PAs, we had this ability to kind of say, like, okay, I'm going to switch this specialty to this specialty because we're generalists in training. So you kind of like make it happen and you do your individual learning. And that sticks more, to be honest. So you were a go-getter from what I'm hearing. Tell us a little bit about how the primary care experience impacted your psychiatry mindset.
I think that's one of the cool things about being a PA is that we are educated in primary care, but then we can work in all these other specialties. But like we always, if we're doing our jobs well, are always bringing in that primary care. Okay, what is the holistic picture here? I definitely have had so many cases over the years where the patient had some terrible anemia that once we got that right, it was much easier to either they didn't have anxiety or depression at all, or it was much easier to treat. Or, we've had patients with their thyroid. I've had patients in alcohol withdrawal that really needed primary care management piece of it really came in handy. When you see patients as frequently as we see them, if you're getting a blood pressure every visit, then you can catch that hypertension earlier, or you're seeing some scleral icterus, you can get them in for their liver labs and catch those things earlier than you would if they were waiting for their once yearly visit or waiting until symptoms actually presented. So I think that was a really kind of fun thing, like almost being a detective there. And on the flip side, I think we get so many patients with somatic complaints that to be able to really reassure those patients that like, no, I personally have done this physical exam and I know I'm not just relying on your primary care and I'm not just relying on, the gastroenterologist or whoever it is. I'm qualified to diagnose this and you definitely don't have it. I've had some very interesting cases over the years where patients come in with these somatic complaints. I've pulled out my laryngoscope and looked in their mouth because they were saying they had something stuck in their throat and it was a hallucination somatic type thing. Like, no, I'm looking in your mouth. There is nothing there. I promise you. Because they thought there was like bugs. Being able to do an accurate assessment and know whether they needed to get that looked at and treated for infections or sutures, just really helps those patients get the quality of care that they deserve and need.
Yeah, I never worked in primary care long enough to get those physical exams scheduled out, but I feel like I have the luxury of time with a lot of my patients to really listen to what they're saying. I send them for labs when needed. And I think about those like annual, if lucky, primary care visits where they get 20 minutes with that provider. And that's where the coordination of care piece can be so powerful when you have those good connections to work together. One of the things that makes us unique as PAs in psychiatry.
That relational piece too, because we do get to know them so much better. They feel much more comfortable disclosing things to us that maybe they wouldn't to their primary care. Or even things like, I'm asking about sexual side effects because they're on an SSRI. Everybody knows that causes sexual side effects. So it opens the door for that question where in primary care, there may not really be a reason to ask those type of questions. I think we definitely serve a really important purpose for those clients and those patients, just making sure that everything's taken care of for their whole quality of life.
Yeah, I think you normalize the question and make them feel comfortable that this is a safe space. That's like one of my like spiel with patients is like, this is a safe space and we can talk about anything. I think that relational connection, that alliance, that being able to say, no, I do have knowledge beyond mental health and psychiatry. And I think that's what I love about being a PA. And there's going to be a talk that I'm going to do on that intersection with psychiatry and physical symptoms. There's this book that keeps coming back in my head, the way that you're talking, called Range. I don't know if you've read the book.
That one. No,
It's a really good book. It talks about having a generalist mind, the way that we can make connections of big picture. It sounds like us as PAs because with our background, we're able to go into each specialty and add extra layers of understanding. Being a mental health clinician, a psychiatric PA, I think we learn a lot about listening is our tool. So, I mean, talking about like how you've educated yourself, what are your two good things? Like if you were talking to a new PA that wants to do psychiatry or mental health, what are your two go educational materials? CMEs, books?
Yeah, for sure. So if it's somebody who's a new grad, I actually just love the DSM, the full size copy, because it's got the flow charts at the back. And I think when you actually dig into that, it helps you really see the differentiators between some of those disease states that can mimic each other. So anxiety and OCD, or OCD and schizophrenia, what are the nuances there? I love reading it. It's interesting. There was also a diagnostic book, and the name of it is escaping me. The First Interview, and there's a few different ones called The First Interview, and I can't remember the one that I love. But when I was a student, I actually would copy out the tables and then cut them out and put them in a binder so that they were all organized.
That's something
So you could have them in your hands. I love that. Just like how to talk to a patient, and it really helps your clinical thinking. I feel like you can't go wrong with a prescriber's guide. That's just absolutely a necessity for every provider in any specialty to have a copy of Stahl's prescribing guide. So those are my three. Massachusetts General is one of my favorite sites for free CME. I do a lot of OCD work. So Shepherd Pratt has really great OCD CME that's free.
Yeah, I think OCD is one of those, we could do a mini series on it, because I think OCD is not well managed, to be honest. And I don't know whether it's the mental health clinician's comfort or whether patients themselves don't recognize it's OCD, or they're scared to mention these weird, fearful, intrusive thoughts. What is your take on the OCD treatment? That it is where it is.
I think it's all of the above. I think as providers, we don't always do a good job of asking the right questions to pick apart normal anxious worries, especially when it's not the disturbing stuff. If it's ruminative or checking or relational OCD, those just sound like normal anxieties until you ask more about it. What percentage of your time is spent thinking about your relationship? And they're like 75%. And you're like, oh, whoa, like that's a lot. Or how is it impacting your daily life? Well, like, can't get my work done because I'm worried about something my partner said this morning. Like, whoa, that's a lot. So, asking those questions, I think, is super important. I don't think patients recognize that it's any different, and they really shouldn't. But then there's also for the disturbing, or people are afraid we're going to, call CPS or send them to the hospital or think they're crazy when
Or shame.
there's a lot of that going on. I don't think we're always well educated on treatment of OCD. Even the drug indications aren't in line with treatment for OCD, and not many things are approved because there's not, the same money behind it, which is understandable. Pratt has one CME on psychopharmacology that is just like, if you watch that 1 hour, it blows your mind, and you can really take that into clinical practice and do a much better job there. But I get a lot of patients who have been treated for OCD, but they're on like Zoloft 100 milligrams, and they're so frustrated and discouraged. They feel so much better when I tell them, well, yeah, like you've kind of been treated, but really, that's not really treatment for OCD. So let's actually treat you. And then if it doesn't work, we can get a little frustrated. But right now, we don't have any reason to get frustrated. OCD education. I love pulling up, like I've got a really good graphic of OCD, the intrusive thoughts and negative attachments, compulsions and distress. We pull that up, talk through it, like, this is exactly what's going on in your brain. It makes total sense. We normalize it, that everybody has intrusive thoughts. Like, brains are crazy. Having intrusive thoughts isn't the problem. Talk about what is and how to manage it. I love working through that with patients.
I had done a dive on OCD, and I came across something that said the general population, like 85% will experience some form of intrusive thoughts. And so that can be very normal, but to the extent in which it's causing clinically significant distress, decreased functioning in their life is when it becomes pathological. What I found with some of my OCD patients is it's almost like a disorder that can wax and wane. They'll have these periods of latency and then these acute exacerbations.
And I think that's a little confusing for patients and providers. If we're not thinking about it holistically, of course, it's going to get worse when you're under more stress, and then it can back off. But we don't always think of it that way.
And being that you kind of are very comfortable in diagnosing OCD and treating it, I know you have your own practice in psychiatry. So do you notice a good portion of your patient population have OCD because they've like, do you know Kathryn?
Yes. And I market it that way. I like treating it. I know there's a need. The way marketing is, niche marketing works better. So that's a niche that we purposely appeal to. My partner and I both enjoy it. So yeah, I mean, we market that. I would say of my new patients over the last year, at least 50% of them have some component of OCD. And that's because we market that way and we connect with other provider like counselors, particularly who focus on OCD. So yeah, we do a lot of work there.
I know you're coming to Psych Congress. We're super excited about the first Psych PA Institute. What are you going to be speaking about there?
Polypharmacy, when to push to add and when to take away. I'm co-presenting with Dr. Albright, and we'll give a lecture on both sides of it. Like when we've got problems, what are the keys to look for to add more medicine? And what are the things to look for to take medicines away and how to do that, like a framework around that thought process so you can apply it to lots of different scenarios.
And having been in the Psych PA world for some time, what do you think about the fact that we're having this whole Psych Congress PA Institute?
I'm so excited for a lot of reasons. One, I think just the idea that we're getting a voice after a lot of years of feeling kind of ignored or not heard or not seen even. There just weren't that many of us. To see that growing and to have a voice at the table and to be taken seriously as leaders and contributors, I think is really exciting. But I think it's just going to be fun. I think as a community, Psych PAs network pretty well. We very much connect and know each other on different levels, but it's going to be really cool to be in the same space as people like Mercedes and I wrote a textbook chapter together and we've never participated in the
Forgot
same
to mention that.
Yeah.
Amazing.
And then like Rachel Holzhauer and I, like we chat probably once a month about crazy stuff our kids are doing and practice ownership, but we've never been in the same place. So that'll be fun. And then I do business consulting as well. And so a lot of people I've worked with are in psych spaces, see people. It's nice. So I think it'll be really fun.
What I love
Definitely.
about this Psych Congress is that it's a conference where we come together as psychiatric PAs or PAs that practice mental health in some format, not necessarily in psychiatry, but in primary care, for example. Our speakers are not just PAs, there's MDs, and I think there might be an NP. We acknowledge that to practice and provide mental health services is a team effort. It is a conference for PAs by PAs, but we understand the collaboration. That's part of the way we practice. It's going to just be really cool to build that network.
It almost feels like a class reunion at this point.
Yeah.
That kind of vibe I'm getting it.
I love that.
Oh, it's going to be so good to see everybody.
Where do you feel like we're going to be in like, say, 5 or 10 years? Like where you see like Psych PAs making impact?
Yeah, I'm hoping there's just going to be more of us and in more leadership roles. I definitely have seen a lot of growth in practice ownership, which has so many different implications. I think that's really important. So I think that's going to be huge. I hope that there's going to be continued emphasis in our PA programs about mental health because it does impact everything else so heavily. And then I'd love to see some legislative changes nationwide that would make it a little bit easier for us to practice. And we're seeing that in a lot of states. Hopefully that continues to make things easier for us.
Legislation is one of the things. Jessica and I met through the Association of PAs and Psychiatry. And one of the things that we kind of connected with is that not every state recognized that psychiatric PAs are mental health clinicians. And I didn't realize that. And I think there's a lot of, disconnect state to state. And so there are states that allow a PA to own a practice. There are states that recognize through their insurances that PAs provide psychiatric services. And then some states don't. And I think one of the eye-opening thing that came to me a while ago was that some insurances won't allow you to code particular psychiatric services if you don't have a CAQ. There's just so much changes and nuances.
Well, even when I first started practicing in Alabama, one of the largest payers in the state wouldn't credential me at all as a psych provider. I had a CAQ, and now one of the insurances we work with won't pay for assessment codes because we're PAs. Just silly things like that. Then there's the whole issue around controlled substance prescribing, which in psychiatry, we work with a lot of controlled substances. Different states have much different processes. I mean, it can be really challenging. Our practice doesn't do any controlled substances because in one of the states, it's just too cumbersome to work around the rules. She is super important, but it's just not my jam. So it's not a huge issue for me personally, but there are times where I'd love to write a short-term script for some benzos and again, it's just too cumbersome in one of the states where we practice. Another state where we're licensed, it would be super easy and not a problem at all. There's just lots of different nuances and different ways that the laws play out. And I think one of the most interesting thing is a lot of times the people writing the laws or enforcing the laws don't have any better understanding than we do of what they mean. They were just written without a clear understanding of what we do and how we function. To translate it is not always clear what the intent was or how to put it into practice day to day clinically. I would love to see a lot of that clarified. And I think if we have the collaborative practice that we're all hoping for, it would really simplify a lot on a practical level.
I talk to a lot of PAs who are either looking to switch into psych or they're new grads and they want to start. And they come to me and they want some like ideas. I'm always like, I have to start with what state you're in.
Yeah, exactly.
And then we kind of know
Makes a
how we
difference.
can navigate a plan from there.
Yeah, it makes a big difference for sure.
So I think there's one question that I felt like we haven't talked about is that, psychiatry is an intense specialty. And I think that as mental health clinicians, we need to be doing what we preach and make sure that we're having good self-care. So what do you do that helps you do your work day in, day out?
Yeah, it is challenging. And I don't know that we think about that, or I didn't until much later in my career. Today was like feel good Friday in my world. I had a counseling visit. I went to the chiropractor. I got a massage. And we're ordering pizza for dinner because like I just am not, today is the day. Like Fridays are just like, we just have to decompress. So, I think building time into your schedule for self-care is really important. Being self-aware enough to know what works for you is important. Helps you deal is probably not going to be the same as what helps me deal. I think recognizing you need to know yourself and tailor that, recognizing that what works at one point or for one situation is not the same that's going to be helpful for other times. Just checking in with yourself. Like there might be a day where I've been like, oh, I'm planning to go to a yoga class. And then I get in the day and I'm like, no, that's not what I need today. I need to sit in the office by myself and cry for a minute. And so I cancel the yoga class and sit and cry and I don't, or vice versa. I think checking in with yourself, the same things we tell patients is important. And I think collaboration and connection, especially like I work by myself, I do telemedicine and I own a practice. I do have another PA that works with us, but not in the same physical space. I have to be very intentional and purposeful about building connections with people who get what I'm doing. We hear a lot of really traumatic stuff all day, every day, just holding space for that and acknowledging how hard that is to ourselves, but then also having people that get it can be really helpful.
I love that holding space terminology. That makes complete sense. If we're not providing care for our own bodies and minds, what capacity am I going to have to hold space for my patients? And I want this to be the safe space. That's what I tell. And so I think that's what I realize is like, I need to recognize, like you said, being self-aware, where my mental health thermometer is myself in order to be able to listen to my patients and be present with them. And it's hard. I mean, I have bad days, but I think I realize that the more that I do my self check-ins, the more that I'm able to continue practicing.
I know on the days like I've had a rough morning or I've got some other stuff going on outside of work that it can be a drain on my patient. Like when you're showing up like your best self and when you're not. And so just doing what I can to make sure that I show up my best for each patient because that's their one time and it's important. So I think that's really valuable to do that for yourself and for your patients, to do that self-care. Another thing I find helpful is I have 30-minute follow-up visits. Don't feel rushed. Some people need 12 minutes and that's okay. That extra 18-minute gives me a little time to clear out the cobwebs and freshen my brain for the next person. When I used to have 15-minute visits with acutely ill patients, you're just running on adrenaline all day. If you're seeing 30 patients, not being in that position is kind of nice, which I love about owning my own practice is that I can do that. If I want 2 hours in the middle of the day to go to a yoga class, I can block it out. So that's very helpful.
Yeah, I always say in psychiatry, I think all professions really like in healthcare. You have to really practice what you preach.
Yeah.
And we're advocating to our patients all the time to make space for themselves and take care of themselves. And if we don't do that for ourselves, it's hard to show up and be present. If you were to say to our listeners, what's one small change they could make this week, someone who's struggling to make a dent in their self-care, what do you think you'd suggest?
What I tell my patients is to find a touch point, like habit stacking. When you go to the bathroom, take a few deep breaths and check how you're doing and what might be helpful. So like when you're in the bathroom doing your business, stop and think, okay, what do I need? Do I need to eat? Do I need to take some deep breaths? What do I need to get through the next 3 hours before I'm back in the bathroom would probably be my first stop.
I love that.
Getting things back on track, checking in with yourself.
Yeah, this is like an enriched bathroom break.
Exactly.
It makes me think of the old smoking days, and people would get their smoke breaks. They would actually get the breathing in the outdoors.
When I worked at primary care, my MA would be knocking on the door while I'm actively going to the bathroom. Like, Kathryn, I'm like, you have got to give me a break.
Oh my gosh.
I'm in the bathroom.
Well, this has been so exciting just to get to talk to you. You are such a collaborator. I mean, you do so much, not only lecturing, but teaching, mentoring, coaching. You own your own practice. You're also a mom, which, you're a super mom on that. Let's say our listeners or followers want to contact you or get your coaching. How do they reach you?
Yeah. So email is always great. Our website is cpacteam.com. So you can reach us there for business consulting. I help other PAs start and grow their own practices, and that can be in psychiatry. We've done pediatrics, dermatology, anything that you really have a passion for to start your own practice. We can help with that.
I love that so much.
Try to step through that. And then existing practices, we've added that as well. So people who need help or support and that collaboration, networking as practice owners, we're offering support in that way too. Also, a part of my self-care is to have a few different things going on so that I can fill different needs, network with people in different ways, and not always be in the psych PA role. For me personally, 40 hours of that would be really hard. I'd bounce around and do some different things that I really enjoy.
I just took a peek at your website. It's amazing.
Thanks.
Listening, check it out.
Thank you, Kathryn, for joining us. Thank you, listeners, to join Mindset Matters podcast. We're going to put all this information up. If you have any questions, let us know. Until next time, stay curious, stay connected, and take care of yourselves and take those enriched bathroom breaks.
There you go.
Awesome. Thanks so much for your time.